This episode of the Senior Rehab Podcast is sponsored by the Academy of Geriatric Physical Therapy. AGPT's mission is to further your ability to provide best practice physical therapy and to advocate for optimal aging. Falls are a big deal with our patient population, but do you find yourself struggling to manage or even prevent falls with your patients? You should check out AGPT's clinical guidance statement on the management of falls in community-dwelling older adults. This paper gives you a clear direction, recommendations, and action steps so you can help your patients. You can get this article for free and learn about how the AGPT can further your clinical practice at geriatricspt.org/SRP. Hit me!
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hello and welcome to Home Health Recharge. I'm Troy Mead. Sometimes when we're trying to implement a comprehensive falls program, we may not be keeping in mind that speech therapy can be a very important part. So I recently sat down with Celeste Cheek and Andrea Travers to discuss what bringing in speech therapy can add to a falls program, as well as how physical therapy can work together with speech therapy in these situations. I hope you enjoyed it as much as I did. So I'm here with Celeste and Andrea Travers. How y'all doing today?
Doing well.
Yeah. And I asked you all to come on because you are working with your falls prevention program, and I found it interesting that you're really incorporating a lot of speech language pathology into your program to help strengthen it and improve outcomes with your patients. So, Andrea, you're a speech language pathologist, is that correct?
Yes, that's correct.
So, from what y'all were telling me, it kind of started with your case conferences. Is that true?
Actually, I think it was kind of an organic thing that kind of developed out of doing co-treatments. So Celeste made a real effort to bring me in when she noticed that she was struggling with patients that were having cognitive communication concerns. Is that fair, Celeste?
Absolutely.
And that she knew that that was a part of our scope of practice. And so she started asking me to join her with some of these patients that she was having a harder time with. And the more we worked together, the more she felt that there was value in general as being a part of a general falls program to bring that cognitive piece in order to better reach the patients.
Right. And we've been tracking our falls, and a high majority of them have, on the cognitive piece, they all have a big fat yes. So I thought that would help as well, because we've got to be able to address this somewhere. You can't just say they're going to fall because they have cognitive problems and move on, because they are going to continue falling. So I stole Andrea.
So let me get this straight real quick. Speech language pathologists can do more than just swallowing. Is that correct?
A little bit.
My caseload is probably mostly cognitive communication. I would say that that's actually a majority of my caseload at any given time. And that has changed over time. When I first started, it was probably half swallow and half everything else. And now I would say it's half cognitive communication and half everything else. Because that's getting out there, that is a component of what we do.
So if a patient is having cognitive issues, is there any strength in bringing in OT and speech at the same time?
Definitely. The speech pathologist is, I really try to use the term cognitive communication, because that really is more descriptive of what we do as the speech pathologist. And the occupational therapist approaches the cognition component through ADLs, and having the cognitive communication and the cognitive through the ADLs together at the same time benefits the patient.
What I like to see too with when I see that speech is brought in with a falls program. First thing I see a lot of times is that it gets overlooked, unfortunately. And like you said, I think it can bring value that can strengthen what OT does and what PT does. And I think you all see that too, especially even with the interdisciplinary communication and kind of strengthening your practices. Does what Andrea kind of brings to the table, does that strengthen your practice, Celeste?
Absolutely. Besides the helping me with the exercise programs, if you've got someone that you have been trying to do something properly in their environment and they're still horribly unsafe, I mean, Andrea, she implants memories. It was the coolest thing I've ever heard. But she can help you to help the patient as well. But now I lost my train of thought. Yes.
You know, one of the things too that I hope as we go through this process is that you know, a lot of the things that I do don't necessarily have to be me doing them. And, you know, anybody, like the implanting memories thing, that it's under what's called spaced retrieval. And it basically puts a memory into somebody for a very simple task that has even a moderate level of memory loss. And, you know, I think that as we work more and more and more together, that those aspects will, that we can become transdisciplinary trained in how to implement those things, so when we do it together, I'm learning how to properly transfer or what this person needs to do as far as getting onto the toilet. And then I'm imparting how to implant those memories. And I just feel like us working together will make us that much stronger as clinicians.
Yeah, I know some of the strongest work I've done with some of my cognitive patients has been in conjunction with what speech has been working on them with. And the best outcomes have been where I can help reinforce what the speech language pathologist is doing. And then on the other hand, they can kind of help reinforce some of the stuff that I'm doing.
Yes. So that patient is getting the same information and the same training from every single clinician. And the more that we're trained, the more that patient is getting repetitions, which is just going to increase their ability to properly do it when none of us are there.
Mm-hmm.
And I think that's one of the biggest things about falls is it's a multidisciplinary, multifactorial thing. So we all need to look at all of it.
Right.
So Andrea's brought a big strength to this program.
So,
I think with your case conferences too, you mentioned to me previously that's a great time when you can kind of reevaluate the patient and whether you need to bring in speech or another discipline as well. Is that kind of where it starts, or are you always thinking about bringing speech in when you see a patient that starts giving you kind of cues if they haven't been brought in already?
I do. I think about it when I evaluate them. I've started doing the mini cog, which I hadn't been doing before. But you know, as you treat them, you start picking up those cues, and I'll ask her to at least come in and evaluate. It may just be something where they're functioning perfectly fine in their environment and do have a little cognitive deficit, but it's still functional. But at least just pulling her in to take a look at it is helpful.
Andrea, is there anything that you would suggest that other therapists or PTs and OTs look at when they're evaluating their patients that would cue them outside of what Celeste was talking about to bring in speech?
Yeah, one of the things that I often say to people is that we need to require the same cognitive communication level from our patients that we do from anybody on the street. And I think that there's a tendency to excuse when people are struggling with that cognitive communication component. and we say, oh, they're tired, or they're not feeling well,
or old.
Or
You do. That is.
Yeah, and we all are going to struggle with our memory at times.
I'm over here raising my hand.
But if our patients are living independently, we need to require that they absolutely 100% know how to administer their medications. And regardless of what reasons that we can put into place to say that they can't do this properly, we need to require that of them. And, we need to require that they have at least a compensatory system for their memory if they're having struggles with their memory. And so I think that if we're having to repeat ourselves more than a couple times throughout the entire evaluation, that's not necessarily normal or typical or safe. People should be able to walk away from our visit and at least have written down the information. If they can't remember it and they didn't think themselves to write it down, that's probably going to be a problem for them. So if they're distracted, if they can't remember what you're telling them, I'm trying to remember that cognitive communication oasis question. There's like one question that covers all of this.
The confusion one, or the
one that Cindy goes over in that. So shifting attention. All of those components that we would require of anybody to live independently, we need to require from our patients. Does that make sense?
Mm-hmm.
Absolutely.
Yes, I think that's a good perspective too. Because I don't know if I necessarily always look at it that way either. Because I think we can all fall into our stereotypes, even how aware, or as the kids call it, woke we are.
Is that the new thing?
Yeah.
Yeah.
I mean, I even here on the senior rehab, we try to fight ageism as much as possible. In the first place, you kind of have to look at it as in yourself. And and it's a hard thing to kind of beat out of yourself sometimes. Is you get that, oh well, they're just that's just the way they are.
Right.
You kind of hear that from the caregiver as well. That they've kind of accepted it at a certain point too. That's just the way Dad is, or that's just the way my husband is. He's always, or that's the way my wife is. They've just always been that way, and they may not be seeing it as getting worse necessarily. They may have, and they may just attribute it to age, but just getting that. I mean, you as the professional coming in are able to have an outside view of what's normal, and then or what can you affect.
Yeah, and I think that we're not comfortable in a lot of ways discussing people's declines in their cognitive communication. I think most people accept loss of strength and in their physical with a certain level of, with more, I think they feel less loss of dignity at losing some strength and then working to gain it back. And I think that people are very fearful of losing or declining cognitive communication. And so they don't necessarily want to look at that. The patient doesn't necessarily want to look at that. And the families, I think, can feel uncomfortable looking at that. And I think we as clinicians can also, I think we often move to kind of excuse in order to save face for the patient.
One of the things I kind of struggle with are my my single step tasks. Do you have any advice or any suggestion on how I can improve that?
So This is an area that I often find myself talking about. And the patients that have a decline in their cognitive communication, or people that have a decline in their cognitive communication, really struggle to follow complex commands. And what I often tell people is you just go down to this single step command. And a single step command will have one verb. And that's a good point of reference, is you give one verb in a sentence. So you say, sit down. That is a single step command. And then people often want to pack in nice words. Please, I would like you to sit down. And that suddenly the command is completely lost in all of this language that is unnecessary for what we are asking the patient to do. And it's more social, but for somebody that is struggling to process, they cannot process that level of a command. And they can't figure out what they're supposed to do in there. And another thing, too, is to break down the task itself. So if we want somebody to stand up, standing up is actually a series of one-step commands. It can come across as a single step, but if somebody can't do that, you might have to tell them, scoot forward, lean forward. And you might have to break down the task for them further so that they can complete it, because they might not be able to proprioceptively get their body coordinated to complete the stand-up command.
That's very helpful.
It is really hard. It is really hard not to add in please, or will you, can you,
or I would like you to.
I would like you to. It's a lot more difficult than you expect.
And it's not necessary for everybody, of course. Right. But we know a lot of our patients that are at risk for falls are those patients that have decreased cognitive communication, and we want those patients to exercise and we want them to get stronger. But they can't necessarily do it unless we break down the task for them. And those are the patients that this would be really important for.
So with the strengths of your all's comprehensive falls program, or that you've been working on, do you have any advice for anybody on how they can make their falls program more comprehensive from some of the stuff that you've learned?
Get a speech therapist.
I like that. Have a speech therapist present at every case conference.
Yep. If you're working on getting their strength, you might coordinate with getting their strength improved. You want to coordinate with the speech therapist when you're making your home exercise programs to see if it's something that patient in particular is going to be able to comprehend. That's made a big difference, I believe.
Yeah. And one of the things for Celeste and I that really, again, that just really developed very organically is that we would go in, we started working together with brain injury patients. And Celeste really wanted her patients to do their home exercise program. So we went in together so that we could make sure that she was providing a home exercise program that the patient could comprehend and that the patient could complete cognitively. And one of the biggest areas of disconnect that I see in what we are providing our patients is that we over provide, especially in the number of words, and we over provide in the number of exercises. And in my experience, even somebody who is not cognitively impaired, they cannot really handle more than 3 things to do. So if we're providing a home exercise program that has 10 exercises on it, that is very overwhelming for most people. And if you take into account somebody who has a cognitive communication impairment, it is pretty much impossible for them to look at that and be able to to do a task progression to manage that number of items. So what we did is we would go in together and I would say, okay, I think this person can handle 2 exercises a week. And just so we would add as we go, but we would start with 2 exercises. We picked the 2 most important. And then Celeste would do the exercise, and as she's doing them, so I'm creating the visual aid so that we're using as few words as possible in order for the patient to understand. We are providing everything in big, bold letters because our patients with dementia they have low vision often. They need extra white space because that brings more focus into the word that they need to look at. And the other thing that I do is I just totally get rid of pictures. They are way too abstract. People don't understand them. They can't follow them. So we create these home exercise programs that have, again, just as few words as possible. And then we do a lot of repetitions with the patient so that when we walk out of there, they can look at those few words and they can know what they're supposed to do. And then I also provide a tracking system so that they can check off when they're doing it. So that, because if they can't necessarily remember, they will either think that they've already done it or they just won't really be thinking about it. But if right next to that home exercise program, they put a check on it, then that gives them another visual cue that they can track and say that they're actually doing it.
You definitely have me convinced. Bringing in some more speech, another look at everybody on the falls just to kind of collaborate more and everything. Is there anything else that you would like to add or anything?
No, I don't think, not off the top of my head.
I think there's a lot of good information here. There's a lot to think about, and it kind of encourages me that there's more interdiscipline communication and thought process and a more holistic kind of plan of care that's being used out there for our patients with falls. So
absolutely. Well, and you know, Andrea has called me in a few times after, like, somebody that we've had on for quite a while, and PT's been in, discharged, and then something changes. She's a lot of times the last one in.
I seem to be the last one in with my patient.
Yeah. So she'll pull me back in to go and look at the environment and make sure that everything is the way it should be, and if there's anything else that we need to look at to make them safer in their home. So,
well, and I really appreciate Celeste's home exercise programs because I approach my therapy from a point of function. I want my patients' function to improve, and I want to make sure that they have a home exercise program that is functional for them.
She likes that I steal some of them too.
Yeah, so then you have to do the Oasis.
Yeah, there's that advantage of getting out quick. One visit ahead.
Yeah, that's right.
That's what I meant.
Yeah, I know that one thing that Andrea has run into with, real quick, on the Oasis when we discharge, they will be zeros all through the cognitive and language parts, and she's in there. So then that's when you're looking at the start of care, when she's going back to look and see what they were. So it looks like they're declining. So I think it's really important that you, I guess, just to portray them properly to start with, really educate everyone on the cognitive piece. Mm-hmm. So that if speech is the last one in, or anyone is the last one in, it doesn't look like they're declining cognitively. Yeah,
I think that brings back to Andrea's point about the Oasis, and what Dee said, or what she heard from Dee, was accurately answering the cognitive questions to cue you to bring in speech if you're not answering them correctly, if they're all zeros when you have somebody.
Right. Well, and it was kind of an off-the-cuff comment, but I felt like it was, there was a lot of truth to it. And we were talking about that cognitive question. And what we said is that, if somebody is a 0, then we should not be spending more than a couple visits with them, because we should be able, if someone is truly a 0, we should be able to hand them everything and they should be able to do it. Mm-hmm. So if we're spending 3 months in with this patient, having that cognitive piece answered on our original OASIS really gives a lot of support to why we are taking longer. And so, having that piece, that component, that cognitive component identified is a big support, I think, for our therapy. And it says it's a good reason why we're still in there. Exactly.
Well, thank you both for your time and all the great work that you're doing.
Oh, thank you.
Thank you.
Hit me. Thank you for listening to the Senior Rehab Podcast. If you only listen to these podcast episodes, you are missing out on 90% of the Senior Rehab Project. Hop on over to seniorrehabproject.com where you can join the movement that's advancing care for older adults. You can join for free or become a part of the Game Changers, where you can get some free gear and access to our monthly meetup. Just go to seniorrehabproject.com. I appreciate y'all, and I'll talk with you soon. But in the meantime, do not forget to stay funky.